With us now, folks, we talk healthcare. Dan Clifton with us earlier, Strategas Research. And joining us now, we're honored to have Uwe Reinhardt of Princeton University, decades of study of healthcare. Professor Reinhardt, let me talk with you, if I may first. If you were to see changes in Obamacare by this new Congress, what would you like to see the new Congress do, if anything?
What I would like them to do is maybe revisit the issue of the mandate. There are other ways to do this. For example, offering younger people in particular a deal they can't refuse. This is an idea my colleague Paul Starr here at Princeton had proposed, where you tell people you don't have to be insured now, but if you do for the next 5 years, you cannot join this new insurance arrangement whereby you can get insurance without having your health status taken into account. Something of that nature.
Yeah, very good, Professor. Dan Clifton, you're more in the trenches here. What will the Republicans do?
Well, it's going to be interesting. This is messaging leading into the 2012 presidential election. So next week, on next Wednesday, the House will vote to repeal the entire bill. The entire health care bill, and then it will die in the Senate. And then they're going to individually vote on the individual mandate. Then they'll vote on some of the tax increases. And really what they're trying to do is have a discussion around what the proper health care policy should be, but also lead into a discussion that this bill was about getting access to 35 million Americans. The next step has to be to get costs down in the health care system, which will be the central plank of the 2013 health care reform bill, which will get done.
Well, that's perfect. Professor Reinhardt, you and I had fewer gray hairs when you and I first talked about this, and it's always there, the Canadian-U.S. differential. Here it is, folks. I took medical expenses off GDP, and I took it back and normalized it to 1997. The yellow line is the expense growth in the United States versus a less steep Canadian line. Professor Reinhardt, are we doing any better, or is Canada and other nations just somehow doing this more efficiently than we've done?
Well, efficiently, you could argue about. Effectively, they do, because they strengthen the demand side by having government's hand in it, and therefore, like Medicare, government can at some point say no to price increases, while in the U.S. we basically have very weak resistance to price increases. There is the private insurance industry, but it is so splintered, each insurer doesn't have a lot of market power. And then you have Medicare, but they cannot really step on the brakes much below private sector fees. So basically, we have deliberately weakened the demand side of the system so that the supply side rules. I'll
go with that microeconomics. Dan Clifton, the microeconomics of Washington is they got to get reelected. We just showed a lot of fancy video there of my next 8 procedures. Okay, great. The pressure in Washington is remarkable. Professor Reinhardt knows that. You know that. What's the new pressure in Washington?
Well, 1 out of every $4 in the federal budget is spent on health care, even before the spending for this health care bill comes in. So then it becomes that debt deficit issue that we talked about in the last segment, which will start driving some of these cost reforms. Tom, let me make this quick point, is that the industry group that got labeled the bad guy was the health insurers in this when we passed this bill. But at the same time, the pharmaceutical and hospital companies were all in support of this bill. At some point, the pharmaceutical and hospitals are going to have to share in some of that pain, and I think that's probably going to be the next step to start limiting the cost moving forward.
Well, Dan Clifton, thank you so much for being us with today. Dan Clifton, a Strategas Research Partner. We're going to stay with Professor Reinhardt here in our next section. With us, Uwe Reinhardt. We're thrilled to have him with us, one of the nation's experts on healthcare. Let's go to one of his recent op-eds. And Professor, you're talking here about some of the inside baseball. You look at fees, volume, and spending at Medicare. Self-referral describes any arrangement in which physicians who are not radiologists refer patients to services and facilities in which they have an indirect ownership interest, rewarding them for such referrals. Professor, what's wrong with doctors trying to make a buck?
There's nothing wrong with doctors trying to make a dollar. The concern here is that they might prescribe imaging that is either only marginally beneficial or not useful at all. And there are health effects, of course, to that excess radiation exposure. But there's also the issue of healthcare spending. It is, after all, someone else's money. that you're burning when you do that. So the issue is really one of a conflict of interest, and there is a lot of literature that shows that such physicians recommend a lot more imaging than physicians who don't have that conflict of interest. And I think that's a legitimate area of inquiry.
Let's bring up medical to the personal consumption. This is a ratio, folks, and granted, consumption's has some noise in it, but Professor Reinhardt, again, Medicare to personal consumption, our medical care, is still very, very expensive. Is there a single bullet to get health care costs lower?
Well, I mean, if you actually look at it, healthcare spending is price times quantity. Our prices in America for virtually everything are much, much higher than they are in other countries. So one of the things that could give is price. We are actually not that heavy users of healthcare. We see the physician less frequently than Europeans or Canadians. We go to the hospital less frequently, but we use a lot of high tech like imaging and other such things. So you could probably get at quantity, but Americans are not really excessive users of healthcare other than maybe some high tech.
Professor Reinhardt, I'm going to go out to the American Economic Association meetings in Denver here. If I can get out of the snowstorm in New York on Friday, maybe you'll be there. I heard you, I believe at AEA a number of years ago, speak very emotionally about the two wars. You had a child that served overseas in our two wars. We have a new Congress today. I'm curious, with your invested interest in our two wars, what you would like to see Washington do about our foreign policy and particularly our war policy.
Well, I mean, Iraq seems to be winding down. We had two soldiers killed this last week, but by and large, that is, for us, a quiet theater. And there is now the demand by the Iraqis that we completely pull out. I personally doubt that'll happen, but that is at the moment the forecast. Now, Afghanistan, the real question is, to some extent, why are we still there? What is actually, the Taliban personally haven't threatened us, Al-Qaeda did, but I'm not sure we're fighting Al-Qaeda there anymore. So I'm not an expert, though. I only have an interest in it because one of our children was involved in it. But he's, at the moment, fortunately, not over there.